Thank you very much. Good morning. It's great to see everyone here, and I just want to thank the American Heart Association and the team for inviting me to be here. I don't know how anyone couldn't be moved by that video. I hadn't seen it before, and it really pulls at your chords. I'm really privileged to be here because I think all of you represent important community work where we're bridging science in the service of our society, and to do that is just a really special thing. And to do it under the auspices of the AHA, which is probably one of the foremost organizations in the country really looking after improving our health. So in that context, it really is a privilege. I'm going to talk a little bit about hemorrhage. Is there a way to get the big slides to come over? Is there a way to get the slide bigger here?
Bigger? Sure. Can you get the slide bigger on the monitor?
Oh, yeah, that's great. Okay. These are some of my disclosures and the ones I put in red that are more relevant to brain hemorrhage. And hopefully you can see some of this. So what I want to do is I'm just going to go through very quickly in about 25 minutes just a very broad overview of brain hemorrhage. It's impossible to cover this in 25 minutes, so I am going to lean in on a couple of things and pick out some things and go out on a limb that I think are important and exciting and happening in our field. First of all, I want to take a step back and just say that remember, brain hemorrhage actually is the end phenotype of a spectrum of diseases that all have a common origin. And ultimately, that's an entity that we call cerebral small vessel disease. So the vascular risk factors, the cardiometabolic risk factors that we know about, all result at the end in different phenotypes: ischemic strokes, lacunar infarcts, cognitive decline, gait difficulty, processes of aging. It's chronic in what happens to the brain. Sometimes it manifests in a lot of different ways, and probably the most extreme clinical phenotype is brain hemorrhage. So it's really on a continuum of brain disorders. We know this, I won't dwell on this too long, but it is the deadliest form of stroke, the highest case fatality rate across ischemic stroke, subarachnoid hemorrhage, intracerebral hemorrhage, has a huge economic impact, individual impact, family level, household level impact, and community level impact of any of the cerebrovascular disorders. And as we know that in underrepresented and underserved populations, they bear a disproportionate burden of this disorder. That's important. Let's just put it in another set of context. When you think about the 5-year survival rate for stage 3 non-small cell lung cancer, it's about 36%. Stage 3 breast cancer, on the order of 60%, maybe that's gotten a little bit better. Ischemic stroke, about 60%. Intracerebral hemorrhage, it's 40%. Now, we're not competing with the other disorders to be better or worse. We need to make gains in all of these areas. But ICH is common and it's deadly. This is the AHA mission. And I'm going to make the argument that the AHA and we have all together done incredible work over the years. We've moved a little bit between number 3 in mortality, number 4 in mortality, number 5 in mortality, and we sort of go up and down over the years. If we want to make a significant dent in lowering mortality in stroke, there are only a few places we can go, and I'll sort of put forward to you that we can't make a big dent in stroke mortality unless you make a dent in brain hemorrhage mortality. This is a tricky graph because it's got a lot of different things looking at basically 20 years of epidemiological data. And I don't know if it's coming up for you small as it is for me, but I'll sort of describe what the graph really represents, which is to say that if you look at the different panels, what you're really looking at is the incidence, at the top row, the number of sort of new cases over a 20-year period of ischemic stroke, hemorrhagic stroke, prevalence, so how many cases are there around of people who have had a particular disorder like brain hemorrhage. You'll look at sort of quality of life in that third row, and in the fourth row, you'll look at mortality, and you have to pay attention to the y-axes, which change on you as you go across. But the message really here is that if you look at ischemic stroke over a 20-year and certainly 50-year period, we've actually made maybe almost as much as a 30, 40, 50% drop in ischemic stroke mortality. Hemorrhage mortality, despite some gains, has had some modest improvements, but it's probably somewhere on the order of about 0 to 5% over 20 years. So where we've made those gains in ischemic stroke, we haven't yet in an intracerebral hemorrhage, and that's either a problem or it's a huge opportunity, and at least I think it's the latter. Brain hemorrhage looks like different things. There are different kinds of brain hemorrhage. They have different consequences. But a place where hemorrhage is also different than ischemic stroke is that you cannot escape hemorrhage without having disability. You can have TIAs and mild strokes. In fact, most ischemic stroke is mild stroke. But you have a hemorrhage and you can't escape disability. And that's why the mean, median, modified Rankin scale is a 3 out of 6. If 6 is mortality and 0 is being intact. So embracing disability is part of embracing actually intracerebral hemorrhage. This is probably one of the most important papers in intracerebral hemorrhage in the last 25 years, which basically says an obvious statement that if you withdraw care in patients that look bad in the first place because you have poor prognostication, you're going to lead to a self-fulfilling prophecy, and then you're going to say, well, it's exactly what we expected. And that becomes a very circular thing. But that was only appreciated 20 years ago. Actually, some of my colleagues at the University of Michigan and elsewhere showed that if you just pause your nihilism and preserve hope in those first few days versus just doing what we normally say to patients in sort of this pseudo-randomized trial, actually, patients who you preserve hope in actually do better. That was another landmark thing only 10 or 15 years ago. So step one we've taken, which is to say that we should preserve hope. This is data from 2 landmark clinical trials of brain hemorrhage, first trying to use minimally invasive surgery. They specifically looked at patients who had been in the trial, and at the end of the trial, after about 1 month, they were a modified Rankin 4 or 5. So these are severely disabled or bedridden patients, patients that you know what the conversations are like. You're not going to do well. Lots of disability. And it's tricky, because we don't want to have false hope. That's the tension we run all the time. We don't want to be the people that give false optimism. On the other hand, when you look at these folks and you look at them 1 and 2 years later, all of the patients who were modified Rankin 4 and 5, you'll see that several of them moved to modified Rankin 3 or 2 or even a few that were a 1. Where there's life, there's hope. Not for everyone. Everybody, like that woman in Nebraska, doesn't have the kind of resources that we would like everyone to have. So we have a lot of work to do, but it is possible. And in editorial, one of the leaders in the ICH field, Magdi Salim, a stroke neurologist in Boston, wrote this, and I'll just go halfway down. Accurate prognostication requires longer periods of evaluation after treatment. Most patients with ICH who die in the hospital do so after decisions are made to withdraw life-sustaining measures. These new findings give us an opportunity to just simply pause and rethink how we think about ICH. So I think oftentimes people overestimate what can happen in 2 years and underestimate what we can do as a community in 5 years or 10 years. And we can do a lot. So where do I think where am I going to go out on a limb? We need to do a lot. I hope that we'll do a lot in recovery, and we will. I don't think it'll happen in the next 2 years. I think the next 2, 5, and 10 years about going all in into prevention and acute treatment. And then actually what the AHA has been the foremost leader on, which is quality of care and implementation. This figure was from a recently published paper that in a nutshell sort of grabs a lot of the elements that have to do with acute care. And in essence, it says that these things that are science-proven, guideline-backed now, we have to put into sort of practice that have to do with urgent, acute pre-hospital management and timely recognition, with acute intensive blood pressure management, with reversal of blood-thinning anticoagulation strategies, with surgery where it's appropriate. Recognizing these things, proving them in science, bringing them to our communities is where we need to really lean in. This is an NIH trial that was just funded by colleagues in New York and Boston just within the last couple of weeks, which is the next big NIH-funded trial for minimally invasive surgery in ICH. We're going to see, I think, the techniques get safer, more effective, and actually more affordable and available for people around the country. So this, I think, just demonstrates the kind of excitement that we're talking about. I'm going to move from acute treatment here and just talk about brain health trajectories. So if you look at what happens at that moment that you have a brain hemorrhage, remember, when we have a stroke and we're in the hospital, it is like you're under the stadium lights. At home, things were difficult. You know, maybe you were in a sort of food desert, your blood pressure was high, life was tough. You have your stroke, it's a tough thing, but in the hospital, you're under the stadium lights. And what happens after you leave the hospital? Sometimes we put people right back in the same situation that they were in the first place, which was tough, but now with disability, even tougher. Why do we do that? How do we do that and expect a different outcome? It doesn't make any sense. And you can see here that brain hemorrhage survivors, who we used to give up on, actually in the years following their brain hemorrhage, if they go back to those same vascular risk factors, this is the kind of trouble that you can see across a bunch of different domains. Well, what kinds of domains? You can have a recurrent hemorrhage, right? Because you haven't treated those underlying risk factors because you thought that the patients were goners. You can have ischemic strokes, people who are prone to bleeding. Remember small vessel disease? They're also prone to clotting. So you've got to have stroke prevention. Blood pressure, we know, is very important for cognitive reserve and cognitive decline. ICH survivors are at higher risk for cognitive decline. And then all-cause death. You can add up these numbers and you can see that even when you survive unabated, you can have problems on the order of like 10, 15, 20, 25% within 1 year. That represents an opportunity for all of us. I happen to be the PI for a national NIH prevention trial called ASPIRE, which looks at patients who have ICH and atrial fibrillation and decides what's the right antithrombotic therapy, anticoagulation or aspirin. We won't talk about that today. SATURN is another prevention trial which looks as to whether or not statins should be resumed for patients that have lobar ICH. But my point is that these trials were just funded within the last 5 years or so, and they represent the first NIH trials in history for prevention in ICH survivors. That's both an exciting thing and it's crazy. Just within the last 5 years, we've had the first NIH prevention trials. Fine, we opened the door. We need to have many more because these patients are surviving, and then we have to help them with the rest of their lives. This is a paper from 10 years ago. Pay attention to the date as much as you do to the data. In 2015, investigators around the country showed that there's a dose-response relationship in both lobar and non-lobar hemorrhage for high blood pressure and recurrent hemorrhage. That was shown in 2015. So what have we done for blood pressure as a community in ICH survivors? Huge opportunity. In our trial, the ASPIRE trial, a trial setting, which is nicer than the real-world setting, at the top line, we're doing a pretty good job, right? Stroke prevention guidelines say 130 or less. But when you look at how many patients are above 150 and 130, you'll see as many as 40, 50, 60% of patients. So even in my trials, where we provide pre-blood pressure cups, we check their blood pressures every 3 months, we've got lots of room to improve, and it's only worse in the non-trial real-world setting. What a huge opportunity for what we already know how to do. So that gets us to implementation. Implementation and quality of care on the acute side and on the prevention side. And the AHA should be really proud. We're proud. I'm proud to be a volunteer because, as you heard earlier, the goal was something like 200 hospitals, and 800 hospitals, including many in this state, in this community, signed up because I think you get what we're talking about. If you look at the number of ICH patients, you can see the numbers here on the order of 10, 15, 20,000 patients that are now entered and to get with the guidelines at the American Heart Association. That's incredible when you think every year there are about 70,000 hemorrhages in the country. So already in a few years, we're capturing about a quarter of the hemorrhages. We've got a long ways to go. We're going to get there, but already a lot has been done. If you look at the AHA ICH initiative by state, you can see your state on here and those of your neighbors, and that's wonderful. We're making a lot of progress everywhere. We've got to make more progress everywhere. And as we do implement this quality of care program, we do something else that the AHA always does great, that this community does great, that's out in the hallways, which is that we develop the science. All of these papers around Get With The Guidelines programs furthering hemorrhagic stroke in broad areas, including characteristics of social determinants, where the AHA has continued to be a champion in these important areas. We're developing the science because we have the scale and the partnership with everybody. That science feeds back into the quality, and the quality feeds back into the science. So it's a really wonderful self-fulfilling prophecy. And with that, I would just again say thank you. Thank you for the work that you're doing and for the opportunity to be here today.
We do have time for questions for Dr. Sheth. If you want to use the microphones, that would be wonderful. Thank you. Thank you, Dr. Sheth.
Good morning.
Good morning.
My question is about the NIH funding. Do you anticipate any changes to the funding of these studies?
I'm sorry, I didn't hear the first part of that question.
Do you anticipate any changes to the funding of your studies from the NIH?
Yeah, just having this conversation with colleagues last night, and an important conversation. I would say yes and no. It's not to say that there are serious threats and concerns. So I'm not someone to have my head in the sand about what the challenges are. And at the same time, that I would tell you that every 3 to 5 years, there are existential threats to the funding for biomedical science and to cerebrovascular work in this country, sometimes coming from all kinds of different directions. And despite those threats, actually, science marches forward. The MINUTE trial that we just talked about, not a trial I'm directly involved with, was just funded within the last 2 weeks, even in the current climate, so that's great. I know the ASPIRE trial, which I mentioned that I run, we continue to receive our funding. And so there are those concerns. I think there are going to be changes. Those changes aren't necessarily going to be always in the negative direction. They're going to go up and down, and it's our job to sort of pressure through that. The worst thing I think we can do, it's kind of like our care for hemorrhage patients. For a lot of reasons, when somebody has a hemorrhage, we take a step back out of respect, actually, and empathy, but precisely when we need to lean in. And I would say the same thing is true for our funding and our science. I mean, because of the uncertainty, oftentimes you feel like, geez, it just feels like the sky is falling and the pressure is in the wrong direction, and you don't know. And I would say that's part of the other side's strategy. So we should keep doing what we're doing. And we're lucky because not just the NIH, the AHA and many of their programs has actually increased their funding. And the AHA is not the only such organization. So in the United States and with our partners around the world, I'm actually optimistic because I would say at any moment in time, we don't have nearly enough funding that we need given the individual and the public health burden. And so we have to keep pushing.
Dr. Sheth, what are your thoughts on patients with AFib who are on oral anticoagulation and suffer a hemorrhage? When should oral anticoagulation be resumed? And if you can just elaborate on that.
Yeah. So I'll tell you, my disclosure is being involved in the leadership of this ASPIRE trial. But what I would tell you is that I think the lesson we learn over and over again that I would submit to you here, in clinical practice and in sort of 30 years of data, what you see is data and practice variance in a lot of different directions. So that's number one. And when you see that, it means that we don't definitively know the right answer, and that's an opportunity for improvement. So that's the first thing. The second thing that I would say is that you hear the term equipoise a lot. Do we have equipoise? I would say there's a competing principle that's maybe even more important, which is the idea of suspending belief. We should try not to have strong feelings about whether or not anticoagulation works, it doesn't work, whether or not they should just go for a Watchman. All of these strategies, actually, none of them are proven strategies. We just have the best available data, and we need the trial level evidence from wherever it comes from. So that's really my strongest opinion. I do think that it's an open question whether it's an overall population or a subgroup, lobar, non-lobar patients, patients with amyloid angiopathy, that would net benefit from anticoagulation. There's observational data to suggest that they would, that they all would, actually. But the trial, we need trials to prove it. If you start anticoagulation, the best observational data seems to suggest that it should be somewhere in the ballpark of 4 to 12 weeks. That's a pretty broad range. The guidelines narrow that a little bit more and say, based on observational data, it should be somewhere around 8 weeks. But the bottom line is, actually, we don't know. We're sometimes afraid of causing another hemorrhage by doing something, putting them on anticoagulation. But by not putting them on anticoagulation, that is a type of passive harm as well if they get an ischemic stroke. So that's a long way of saying, if you're going to do anticoagulation in clinical practice, probably somewhere between 4 and 12 weeks is reasonable, but to just not have strong opinions and to look for trial results.
Hi, my name is Naroz. I am a vascular neurologist. I have a tricky question. We just discussed that the median MRS for ICH patients is 3. So when you see a patient with devastating ICH, at what point you start talking with the family about end of care discussion and all of that stuff? Like, is there a standard or it's day to day?
I would say that there's a science and there's an art. The guidelines based on science, some of the science which I shared with you, actually do provide a standard based on the guidelines. And that standard is to really sort of pause in the vast majority of cases without giving sort of definitive, especially definitive negative prognostic things within the first 24, 48 hours. And I think that's pretty backed by the science and the guidelines that are on your table. I would say beyond that, the question is, when and what does the conversation look like in the first week, in the first days in the week, because that's when this becomes relevant. And I would say within that, there is the art. It is when and how you can talk to patients, and usually actually families or partners or their community. And I think you should start to have that conversation right away, within the first couple of days. Because the conversation is about developing, what I think everybody here knows, was just developing a relationship. For some people, it's very rarely sort of one sit-down family meeting, 1 hour conversation. It's a series of 5 and 10-minute conversations that may coalesce into something, and developing sort of that relationship. What a privilege it is to be pulled in so acutely to someone's sort of devastating illness. And then at least what I've learned from others and in my own experience over the years is to structure a conversation with patients and families during that first week that isn't just about the goal. We all naturally think, what are the chances? What are things going to look like? What are the chances in 3 months? Doc, what would you do if it's your family? What is the best case and worst case scenario in 6 months? All super important. We should have that conversation the best we can. We should have humility about what we don't know with the kinds of data that I presented. But I would say there's a second element that I think just as important to share with patients and families, which is it's not just about the destination, but it's the journey, And your loved one has to be sort of on board with both, what the process might look like traveling the road to find out what 6 months looks like and what 12 months looks like, and to really sort of articulate that. That's the piece that I find people don't naturally talk about, because many of us are really goal-directed and trying to think about how to solve a problem. People's lives have been turned upside down. So that's what I've found have been sort of some of the best practices I've seen, but it's an art.
I just had a quick question. You kind of mentioned, overestimating what we can do in 2 years, but underestimating what we can do in the longer term. Is there something on a more local level that we are maybe able to accomplish? Like, what would you suggest all of us to go back to our centers and do? Or is there something that you think is the most important, or something that we can do that's actionable now?
Yeah, thank you for that question. I think, first of all, creative ideas about what's important can come from anywhere. So I wouldn't pretend to tell you what you can do. I think actually you can do a lot at your center just by being here and thinking about it, and you may have ideas, and I really mean that. The second thing that I would say is that some of the principles I think you do take here, I think it's not because people are lazy or don't know, or I think it's just that there are certain limbic or emotional sort of associations that are so embedded. There is still, despite considerable progress, there is a lot of, I think, discomfort and prejudice even when it comes to disability in stroke. And hemorrhage is going to have more disability. A brain hemorrhage also just sounds really bad. Stroke sounds bad, but a brain hemorrhage sounds like, geez, you just had a brain hemorrhage. And these things are bad, but I guess if you just went back and talked to other nurses, to the patients, to the docs on the team, the multidisciplinary groups, and said, you know what? We shouldn't be so negative from the beginning. When the patient's sitting in the waiting room, we should be sprinting to the CT scanner, even if we know they're a hemorrhage that was transferred from the outside hospital, because we need to move quickly, you know. We're not thinking about things that we know are scientifically backed, like blood pressure management, like anticoagulation reversal, like we're ingrained to do for TPA. The AHA is pushing that, but locally you can go back at your hospital and you can do that. And I've been excited to see both here and at AHA meetings, actually sort of single-center, nursing-driven sort of posters about how they improve those quality of care processes around hemorrhage, because nobody was even thinking about that for hemorrhage. So actually that is all local. And I think that's the first part of it, just reshifting the mindset, actually. That may be one of the most important things that you can do. And then I think you can do that with your families. I think we're all nervous because we don't want to say something that's not accurate. We don't want to give false hope. I just tell you, I think we overdo stepping back and being cautious. We need to be a little bit, you know? You think the interventional cardiologists and the surgeons have a problem doing this? No, we can learn from them. Thank you again. Really appreciate it. Pleasure to be here.
Thank you, Dr. Sheth.